All right, well then let's get started. Thank you very much for the invitation. Dr. Steve Delisi with the Hazelden Betty Ford Foundation, and also quite blessed to be on the board of the Steve Rummler H.O.P.E network. And it is my opportunity to talk today about the opioid crisis and epidemic. Really what it is, it's an overdose epidemic. And it's an epidemic of the substance use disorder that we've been talking about all morning thus far. Fabulous presentation on stigma, and then one of the best reviews that I've heard on pain management without opioids. Now we're going to pivot and we're going to look at, why? What is the reason that we're spending this time together? And it's driven by the U.S. opioid epidemic. And this has been going on for decades. We ignored it for decades because, quite frankly, it wasn't the populations and the communities that we pay attention to. And that was also discussed this morning in terms of the marginalization and the systemic discrimination that has been true within this issue. I'm going to start with some trends. I'm going to start with where things started, where we are now, and then really dive into what's driving the spikes in overdose deaths in our nation. So if we think about this epidemic of overdoses, we're actually on the fourth wave. The first wave was the wave of the prescription opioids. This began in the mid to late 1990s. It's depicted in that kind of light blue. But it began when there was a push to make pain the fifth vital sign. And the idea was that we have to be assessing anyone and everyone coming into a healthcare setting for pain. And then if their pain was not a 0 out of 10, then we needed a pain treatment plan. And unfortunately, back in the 1990s, really the treatment plan were opioids. And also right at this time was the proliferation of highly potent synthetic prescription opioids like OxyContin, for instance. And that drove us until about 2010. And as mentioned, around 2010, 2011 is when we really started to pay attention and to say, hey, wait a minute, we're literally flooding the market with opioid pain medications, and people are dying. And so we started to educate the healthcare system about this. We talked about flipping the narrative in terms of opioids not being the first line. And that has had some positive effects. We're making progress. At the peak in around 2011, 2010, in areas up and through especially Appalachia, there were more prescriptions of opioids prescribed than people in the state. So if you look at West Virginia back then, they had more prescriptions per capita than they had citizens in West Virginia. Here in Minnesota, we capped at a bit over 50%. But still, we had enough prescriptions to provide 50% of our state with opiate medications. As that started to decrease, right, there were very significant opioid use disorders that had developed as a result of flooding the market with opioids. And those individuals weren't going to just be able to stop, right? We saw some of the comments that was in the stigma presentation that said, just don't do drugs. Just stop. Listen, if it was that easy, we wouldn't have events like this, and we wouldn't have the number of people who are dying from this illness that we do have. That's all well and good if you don't have a substance use disorder. What we then saw around 2010, and you can see that depicted in the dark blue, was the increase in overdose deaths related to heroin. So as we decreased the accessibility of prescription opioids, highly potent and pure and less expensive heroin started to hit the market. And that continued well into about 2014, 2015, when we saw the beginning of the illicit fentanyl. Everybody's heard of fentanyl, I'm assuming? Yeah. So when I started in this field 22 years ago, the only individuals who I treated for fentanyl use disorders were healthcare professionals. They were the ones that had access to the pharmaceutical grade fentanyl. That is a prescription medication. What we are seeing on the streets is not at all that. It's illicitly manufactured, it's fully synthetic, and its advantage, if you will, from a drug delivery perspective, is that it is inexpensive to produce, fully synthetic. You don't have to start with a plant, right? Heroin, you got to start with the poppy. You got to start with the poppy plant. So you have to do agriculture and then ultimately convert it into heroin. Here, you just go in your lab, you cook it up. It's odorless, it's colorless, it's easy to transport. We're never going back to heroin. That's not where we're going to, what we're going to see. We're going to continue to see more and more potent synthetic drugs. And so now you see that massive spike into 2019. For a moment in 2018, we started to flatten out, and then the pandemic hit. And the pandemic was catastrophic for what we're talking about today, and it ushered in the fourth wave. And that fourth wave is polysubstance overdoses, driven by the high-potency synthetic opioids. But now we're seeing that with a spike in methamphetamine and other synthetic stimulants and illicitly manufactured and very strong benzodiazepines, anti-anxiety medicines, that when combined with an opioid really contributes to the lethality. And that's what we're seeing today on the streets. This region may be relatively lower in number of overdoses as you look across the state and the country, but there are consistent clusters of overdoses that are related to methamphetamine and fentanyl in this county. So, drug overdoses in 2021, this is the most recent data. This is state level. And you can see, again, that it just continues to increase in spiking. So we're continuing. And actually in 2020 was the first time that in the United States we had over 100,000 deaths in the year. The light blue bars here depict the increase in fentanyl overdoses that are related to fentanyl. And so you can see how that last year increased to over 70,000 deaths. What that equates to is a 20% increase from 2020 to 2021. It is 107,000 people lost their life to overdose in the United States. And to put that into terms that are really, I think, hit home, that's someone dying every 5 minutes. So in the time, I'm looking at the clock, in the time that we've been talking, 26 people have died in this country since we started at 9 a.m. 26 people. And every 5 minutes, just clock it off, it's another person who's died, another person who's died, another person who's died. So that's going to lead us into discussions on ways that we can reduce that risk. We can reach out and we can meet people's needs where they are at, and we can work to save lives. This is just, again, depicting the fact that the lion's share of overdose deaths are related to these potent synthetic opioids, but there are other prescription opioids, heroin, cocaine, methamphetamine, and again, what we're seeing really spiking are these illicit benzodiazepines. So, Let's unpack fentanyl a little bit. You hear about it on the news all of the time. What is it? Again, I mentioned that we have a prescription medication, fentanyl, that has been used and is still used. That's not what I'm going to talk about today. I'm talking about the illicit fentanyl, that which is made in illegal labs. And it has really continued to increase. We now have fentanyl. We have analogs where they just tweak the compound a little bit to make it even more potent, or to make it so that it doesn't show positive on tests. And we have things you're going to start hearing, if you haven't already heard, terms like nitazines. Be listening for nitazines and xylazine. These are even more potent synthetic opioids that we're seeing cluster deaths across the country. This is a really important slide, and important for you guys to take away from today, right? It's not just that we have drugs on the street that are being sold as opioids that contain fentanyl, because fentanyl is an opioid like heroin, but it is being found in other substances or in tablets that are being sold as something else. So if you look at this on the top picture here, this is real oxycodone and this is real Adderall, and on the bottom are the fake. And those fake tablets are being sold as oxycodone or sold as Adderall. So Adderall is a stimulant. It's a medication for ADHD. If someone thinks that they are purchasing Adderall, it may be 100% pressed fentanyl and not the stimulant that they think. What I don't have as a picture is that there are Xanax bars. If you've heard of Xanax, again, anti-anxiety medication. The Xanax bar looks exactly like a fentanyl pressed bar. And that was just reported. It was actually on a social media thread. One of the people that I am connected to, he lost his 20-year-old who was in a stable recovery for 6 months, had a moment where he reached out and purchased Xanax. That Xanax that he purchased was actually fentanyl. And that young gentleman is no longer with us. So that's that expansion of the risk pool that we want to make people aware of. There are case reports of fentanyl-laced THC, cannabis, marijuana. It's not very common, thankfully, but it is there. MDMA, ecstasy, mollies also can be laced with fentanyl. Some of it is actually intentional. There's an intentionality that, hey, we're going to create this, we're going to sell it at something else, but it's going to cause a real high, a real effect, and then will be known as having the good stuff. That's intent. Other times, it is by incidental contamination. It's not as if the labs and those who are putting together these substances are working in quality-controlled FDA labs. And so there can be contamination. And we need to be aware of that. And that's what we're going to talk about as I pivot more to discussing ways that we can reduce harm. I keep saying high-potency synthetic opioids, high potency, high potency. That just means extremely strong and extremely dangerous. 2 milligrams, 10 to 15 grains of fentanyl is the lethal dose. 2 milligrams. These vials show the lethal dose of heroin, and you can see the white substance, then of fentanyl, and you can barely see that the very bottom of the vial has some white, and then there are 2 or 3 grains here, that's carfentanil, a large animal tranquilizer that is 10,000 times more potent than morphine. And that too is on the street. So again, even if someone has been using other opioids, they're going to be at risk of overdosing with what's on the street today. If they have gone to treatment or they have been incarcerated, their tolerance for opioids decreases. They then go back out on the street, and if there is a return to use, that can be lethal. I mentioned that I've been in the field 22 years. We mentioned in the first presentation of today that the field of substance use disorder has been dominated by focusing on abstinence as the primary outcome. I remain an abstinence-oriented clinician, but that means that all pathways to healing are open. And I'm going to sit down with the individual that I'm working with, and we're going to determine what their pathway is. In the past, it was that it had to be abstinence right from the get-go, which, if you think about that from a chronic disease model, and we equate it to diseases like heart disease, hypertension, asthma, arthritis, abstinence is the equivalent of no symptoms, remission of all symptoms. Any of you who have gone to the doctor, any of you who have had, even let's throw out, we're in the midst of a pandemic still with COVID. We're now starting with flu season. If you've got kids, they've got RSV, and you've been dealing with that. When they are given, when we take medications for any of those, do we go from symptoms to no symptoms right away? No. There's a period of time where we're still symptomatic. And that's what we're talking about, right? But the problem is as someone is still symptomatic of their substance use disorder, these substances being on the street can be lethal. It could be end stage. We have to keep people alive, right? Does that make sense to people? That's what's changed. This is also, I think, a really helpful slide to conceptualize, again, why this is so dangerous. When you are going to make one of those fentanyl pills, the way that you do it is you take powdered fentanyl, you combine powdered fentanyl with some binders that are going to form the pill. Like when you take your acetaminophen that we heard about, that whole tablet is not acetaminophen. It's got a little bit of acetaminophen, and then it's got these binders and fillers. So you take that, you take the fentanyl fillers, you put it together, and then you start to mix it up. In a FDA approved lab with quality control, they make sure that mixing mixes the medication equally for all tablets. So one tablet of acetaminophen, 325 milligrams, and another one is going to have the same amount. Again, these are not quality controlled labs. Right? And so what happens is you get this pattern where some of the tablets have very little, that little dot. The analogy is the chocolate chip cookies, right? You make chocolate chip cookies at home, some of your chocolate chip, well, for those of you who are really obsessive compulsive, you've mixed and stirred and you make sure, like that's my personality. I've got family members, they know. I'm going to pretty much make sure each cookie is plus or minus one chip in similarity. That's not the case when we're mixing up fentanyl tablets. And so on the far left, you got a cookie with just 1 grain of fentanyl. And on the far right, that entire tablet is fentanyl. And as I said, once you get to 2 milligrams or more, that 1 tablet is lethal. Not several tablets, and the DEA has looked at that, and they have found that in the U.S. right now, of these illicit, illegal, on-the-street tablets, 4 out of 10, 40% of the tablets are lethal dose tablets. That's really high risk. Also, very important, after lunch, I also recognize that I'm kind of the before lunch presentation here. After lunch, we're going to dig down and go through what is an opioid overdose, what does it look like, and how do we reverse it with the use of naloxone or Narcan. So I'm not going to go into detail there, but there are differences with the overdose when it is fentanyl or one of the fentanyl analogs. And remember, right now, most, if not all, of the opioid supply out on the street is containing fentanyl. In most regions in the U.S., including here in Minnesota, that which is called heroin is not heroin. It's fentanyl. Because again, easier, cheaper to make fentanyl and call it heroin than to actually start with the poppy plant and get to heroin. We're not going back. So it's really important to recognize that there are differences with these fentanyl compounds. And again, my anesthesiology colleague and other health professionals, especially those that work in the OR or in trauma, they've known for a long period of time that fentanyl in overdose can cause rigidity, stiffness, and the whole chest becomes tight. And the airways in the throat seize up and spasm. You can have spasms of the tongue. This is really, really important. It's A, the primary reason why fentanyl overdoses are so often lethal, and B, why you can't just say that we're going to do basic life support with rescue breaths, because your rescue breaths may not be as effective in the face of a fentanyl overdose. If the whole airway is seized up, how effective, unless you're going to do a intubation. But if you're a first responder, if you are someone in the community who has seen someone and they're down, this is why it's so important that we combine. Absolutely, gotta be doing basic life support, but also be equipped, be educated, be trained, and have on you naloxone or Narcan, so that you can give that life-saving medication. The other thing that we can do is we can ensure that there is a degree of safer use with individuals who are using substances. And this is where we can have a significant impact, and there are a lot of studies now that have demonstrated the impact of fentanyl testing strips. Here in Minnesota, using and possessing fentanyl test strips is now legal. It used to be illegal. It was drug paraphernalia. Now it is legal. If you go to the Steve Rummler website, you can get more information on fentanyl test strips. They've got a wonderful video. Really, honestly, at this point, if you Google fentanyl test strips, you can get 3, 4, 5 videos right at the top of how to use them. Why would you use them? You would use them to test, is what you're about to use what you think it is? So if you are like that 20-something-year-old who bought that Xanax, if that individual had a fentanyl test strip, could have taken a little bit of a chip off the Xanax, mixed it with 15 milliliters of water, let it rest for about 15 seconds, and then put in a dipstick. And when you put in the dipstick, you wait, again, another 30 seconds, 60 seconds, read it within about 5 minutes, and you will see, this is just a PDF of how to do it, but this is what you will see. And if you come up with one red line, that means that that supply that you have is positive for fentanyl. If you see 2 lines, it's negative for fentanyl. It's at least negative for fentanyl and the analogs that this tests for. It's highly sensitive. It does a really good job if you've done the test right, and if the fentanyl that's on the street is what this can test for. So it's not 100%. This is not where now you know that the supply is safe. It's that it's safer, or it absolutely contains fentanyl. Hard for me to read. Don't know how you guys can read it, but I'll unpack this. There have been a number of studies that have asked the question: when communities have access to fentanyl test strips, does it have any impact? Like, do they do anything? And what they have found is that actually, yes. When you look at it, the most common, and so that which is circled in red, is that by having the fentanyl test strips and being able to use the fentanyl test strips, it didn't necessarily stop use. There are some who say didn't use that supply, but more often it is didn't use alone, used a lesser amount, went slower, made sure naloxone was present. Further in, kind of in the middle grouping, they also shared the results of the test results. Shared it with their friends, shared it with those around them, shared it with the individual who sold them. Because a lot of times the person selling the drugs has absolutely no idea what they're selling, just what they were told it was. And so you're seeing an impact at the individual level, but also at the community level, moving towards safer environment in which the use is happening, right? Again, because of misunderstanding and stigma, also because of, at a national level, some compassion fatigue. I love that inclusion in the first presentation. There is this sense of, do these measures have any impact? And what we're here today to talk about is, yes, they really do have an impact and change behaviors, and those change behaviors can then again result in lives saved. Some fact myths, go quickly. One of the myths about fentanyl testing strips is it encourages people to use drugs. Here's the take-home message. People, especially in the United States, use drugs. And prevention strategies like just say no do not work. And in 2022, if Delisi had given me more time to talk, we could truly unpack the science of why just say no doesn't work. And why, even before someone uses for the first time, choice in the way that we think of it, those of us, I'm putting the we, those of us who do not have the lived experience of a substance use disorder, choice is different. Choice is very different. And once someone is active in a use disorder, the brain changes are substantial. And we know them now. The problem is we don't get that information out enough. I'll definitely be here all day and at lunch, happy to answer questions about what am I talking about when I say we definitively know that the fentanyl test strips are not an impact on whether or not people are going to use drugs. It's actually a myth that just puzzles me, because fentanyl test strips are pretty new, and we've been struggling with addiction forever. So it's like, what are we talking about here? Number two, fentanyl dangerous to touch. This is a really important one. This is an important one because I just got through talking about how dangerous fentanyl is, and I certainly don't want people who are perhaps a first responder, are law enforcement, or again, are a concerned citizen, don't want them to be at increased risk, right? And so there's pretty much every month there's a story on social media about how incidental contact with the skin, the person went immediately into a fentanyl overdose. That is not something that happens. There are fentanyl, they're called the duragesic patch. So there is fentanyl in patch form, but that's specially developed to be effective at absorbing over time through the skin. The most risk is if you're ingesting it, you're snorting it. If you got enough in your eye, there would be risk. If you had open wounds, and I'm not talking like you have a little cut, you got a Band-Aid on it. I mean like you're bleeding and you got this gaping wound. Then if you had exposure to fentanyl, that would cause risks. If you were in an enclosed case that had particulate fentanyl all over and you're breathing that in, that would be of risk. But if you're at a scene where someone is down on the ground, not breathing, unconscious, turning blue, and with pinpoint pupils, you're not at risk in engaging. That's what's important. And then finally, fentanyl, is it naloxone resistant? Is it that now we're at the point where there is no hope? No. Naloxone, you'll learn exactly how naloxone works, but basically when you give it, it goes to the brain and it tells the other opioids to get off the binding sites in the brain, kicks them off, and the person goes immediately actually into opioid withdrawal. With fentanyl being as potent, and it is very sticky to those receptors in the brain, you do sometimes need multiple doses of naloxone for it to be therapeutic. But if you give the right dose, you get the same effect. Fentanyl test strips will not tell you how much. We don't have tests that are available on the street to say, is this one of those pills that has 2 grains of fentanyl, or does it have all of the chocolate chips? It's just going to be positive or negative, so that it's not going to say. And then a negative fentanyl test strip result, don't want anybody leaving here thinking, well, if it has the 2 bars, I'm good to go. Because it may be that it's a substance and it's an opioid that this test strip does not pick up. Or, remember, the high-potency stimulants and the benzodiazepines that are out there, they're lethal in and of themselves, especially if you're combining that with alcohol, right? I've spent a lot of time talking about overdose deaths. There is a similar amount of deaths every year in this country related to alcohol use disorder. So alcohol is something we need to focus on too. All right, so let me pivot and then we'll open it up to questions. What is harm reduction? I've mentioned harm reduction. I've mentioned making things safer. But what are we talking about here? So basically, harm reduction is doing anything that reduces the risk that some harm is going to occur. And examples within a substance use disorder, or those individuals who are using drugs that can result in terms of harms, HIV/AIDS, hepatitis B, hepatitis C, other infections. Those who are injecting drugs are increased risk of infections of the heart, and we want to avoid that. I've made a big point about overdose and overdose deaths. One of the things that we're not paying enough attention to are the non-fatal overdoses. Right? Again, after lunch, you'll learn about opioid overdoses, and part of an opioid overdose is that the person stops breathing. Stopping breathing is not good for one's life and one's brain health. And so even non-fatal overdoses are something that we really need to reduce. The resources that we have, I've mentioned naloxone, talk about the fentanyl test strips. Medication, so MAT, those are medications for opioid use disorder, medications for alcohol use disorder. We do have FDA-approved medications as one part of a treatment approach. Not the full story, but they can be really, really significant. Needle exchanges and safer smoking kits, really important. And we'll talk a little bit about this at the very end of the presentation. And again, when people start hearing about safer sterile smoking kits and syringe exchanges. Again, one of the things, and I think we've got a myth slide, doesn't that now promote drug use? Again, no. Drug use happens. So anytime we start with, isn't that going to promote drug use, it negates and ignores the fact right now, and now we're at another 1, 2, 3, 4, 5, 6, 7 people that have died since the last time I said that people were dying from an overdose. It's happening right now. So what we're talking about is not ignoring the issue, which has been what we've done for decades, nor trying to criminalize all of it so that we're going to try to consequence people out of a use disorder. That also doesn't work. That, again, very clear brain science, that's a failed policy. And so we want to be utilizing the things that can be safer. I will also say, because there's a big, huge hoopla in terms of safe injection sites, right? These policies are at the fundamental core ways that we are all trying to reach out and extend a loving hand to individuals where they are at. And because of the structural, societal, and self-stigma, they often do not feel as though they are worth anyone reaching out that hand. And any hand that we reach out to them is a hand and a way in which we connect as humans. One human valuing and respecting the intrinsic value of another human. Why? Because they are who they are. Period, end of story. And so when you see people who are handing out syringes, and when you see people who are staffing safe sites, they are giving every individual who walks in, they are able to see in their eyes, I'm here because of you, and I'm here because of you because you are another human being. You are one of my neighbors. And too many of my neighbors are dying. That's how we change the dialogue and the conversation about all of this. Is we sit down at the same table and we say, all of the people that every 5 minutes someone's dying, that's one of our neighbors. Right? So I'm not going to ask people, but most of us in this room know someone really close to us who is either no longer with us or who was almost no longer with us. And it's got to stop. It has to stop. Abstinence. So, okay, anybody in this room who knows Hazel and Betty Ford, who I work for and have worked there 17 years, knows that we have been a treatment program grounded in abstinence. We haven't jettisoned that. Again, one of the treatment outcomes is to work with individuals to get to a place that they are abstaining from the use of alcohol and other legal and illicit addictive substances. But what has shifted is the recognition that harm reduction and having an abstinence orientation are not mutually exclusive. That dichotomy and that conflict is a false dichotomy and conflict, and the only individuals who get hurt when we're warring with each other are the individuals, again, who are dealing with use disorders. That harm reduction is a way in which we reach out and we extend our care to individuals anywhere and everywhere they are, and a recognition that outcomes aren't all about full remission of everything. We honestly don't think about it that way for most other illnesses. And we certainly, as I made a point earlier, we don't say at the very beginning of treatment and working with you, you have to be completely asymptomatic. And if you show any symptom of your disease, I'm not going to work with you anymore. That is how we used to do it if you were abstinence-based. You're still using. Well, then, we'll We'll leave the light on, come back when you're ready. Or who in this room has heard the phrase, individuals with addiction, they'll seek treatment when they hit rock bottom? That I'm going to ask. Anybody heard that? Raise your hand if you've heard that. Thank you. Here's the deal. Name me one other illness that's what we say. Right? Let's say heart disease. The equivalent is we're going to wait for everybody to have multiple heart attacks. And once they've had a number of heart attacks, then they can come into treatment, and the treatment is going to be open heart bypass surgery. We're going to do open heart surgery. We don't do that. We look and say to ourselves, what are the risk factors of heart disease? How do we get at this so that they don't have a heart attack? Or think about cancer, right? Cancer, wait till they hit rock bottom. Cancer, that's metastatic. That's stage 4. Do we wait for people to hit rock bottom? Nah, we're not going to treat them. Don't worry about it. And we can't possibly use the most effective treatments until they've failed other treatments. We do this for use disorders. It is getting better. I want to echo that. We're making progress in the last decade. But we have so much further to go that, quite frankly, this whole room should be standing room only. Because it's all of the people who are not in this room that we need to make the big impact. So those of you who have come and are in the room, thank you. That includes all of you around and who are doing this work every day. Keep putting the word out there, and let's get more people in the room. I do get preachy. I just can't help myself. So other harm reduction. Here are other examples of harm reduction that we don't even think twice about it. Wearing seatbelts while driving is in fact harm reduction. The utilization of birth control and prophylactic is harm reduction. Trying to offset the effects of alcohol by drinking water is harm reduction. It is. It's not the most effective harm reduction. I don't put that out there as a real evidence-based practice, but that is harm reduction. There are key tenets to harm reduction and principles. Number one is, again, it's minimizing any harmful effect. So we're going to say individuals are going to use substances. That's not to say that then we don't look for opportunities to help them to see, is their use of substances markedly impacting multiple aspects of their life? Like, is this someone who part of their harm reduction is referring them into some level of treatment, right? That is part of harm reduction. Number two, recognizing that substances exist on a spectrum. Absolutely. Here's something that people miss. Most people who use substances do not have a substance use disorder. Most people who use substances do not have a use disorder. We focus on those who have a use disorder because it destroys their lives and the lives around them. And we want to, again, help with them. But there are individuals who are truly using in a way that's not destroying all aspects of their life. But if they get one of those cookies with 18 fentanyl chocolate chips in them, now they're dead. They went to a party, they used some pills, they do not use on a regular basis, and now they're dead. That's the problem. We need to reduce that risk. We also, again, abstinence is a goal. It is a legitimate way to approaching, in particular, severe use disorders. If you look at the literature and you see what are the best outcomes long-term for individuals, having them get to a place where they are not using anything is the best. But there are a lot of other opportunities to impact and improve their quality of life, the quality of their family life, the quality of their work life, the quality of their community life. And those are legitimate outcomes. And we need to look at that as well. Provide services and resources that assist people in reducing their harm. Yes, we can't just say, here's the naloxone, here's the fentanyl test strip, figure it out for yourself. We have to get out there and we have to make it so that it's possible. 5 and 6, I cannot express with more passion how critically important 5 and 6 are. If we are going to be effective in helping individuals who have lived experience and are actively using substances, the individuals who can help us to be most impactful are those who have that experience themselves. They know what is effective, they know the messages to convey, they know the people who are the connectors in the community, and again, my editorial for, and we're recording it, so for posterity, is we just have been ignoring that for too long. And it's time to really look at 5 and 6 and say, yes, that is a critical part of our approach, as is 7, that we recognize that there are very real issues around structural and institutional racism, generational traumas, marginalized communities, and all of what we talk about as the social determinants of health that directly contribute to one's risk of being an individual who uses substances and the risk of then going on to develop a use disorder. So again, in that analogy with cancer and heart disease, what have we done with those illnesses? We've looked at prevention and early intervention. That's what we need to do. And part of prevention and early intervention is dealing with our deep national issues around racism, generational traumas, and the social determinants of health. And then finally, does not attempt to minimize or ignore the real and tragic harm and danger associated with substance use. This is not condoning use and saying that use is safe. Here's another take home. Any substance use with addictive substances, any use has risk. There is no safe use. It's safer use or higher risk use. The safest is not using. And again, for individuals who are not genetically and epigenetically predisposed, that works pretty well for us. We can just say, not going to do it. But for a lot of other individuals, that's not part of the equation, and those are the people that we have to have compassion for. Harm reduction strategies, and there they are. Try using only one substance at a time. Really important. You combine anything that is sedating, anything that makes you groggy or tired or prone to falling asleep. So that'd be alcohol, that'd be anti-anxiety medicines like the benzodiazepine. There was mention of gabapentin, Neurontin, which can be helpful in pain. When combined with opioids, gabapentin is associated with a higher risk of overdose. Antihistamines. Who took an antihistamine today for their allergies? I did. I selected a lesser sedating antihistamine, but something like Benadryl, that's used commonly across our society. Using a sedating antihistamine with an opioid like fentanyl increases one's risk of dying from overdose. So, and alcohol, absolutely alcohol across the board. Do a test dose, right? So if you're using something, don't just use the whole supply all at once. Smoke and snort instead of injection. Injection increases the risk of infection. I will say this though, the snorting piece also you need to be cautious. Injuring the mucosal, the nasal passages with like a straw and cutting it increases the risk of HIV and the hepatitis C's. And so sometimes people think, oh, I didn't inject, I'm not using a needle, but snorting with straws can carry a similar risk. Use it slowly, monitor one's response to it. Yes, get supplies that are sterile. Don't be reusing needles and straws. Don't share around. Really don't use alone, and ensure that when using, especially in the era of fentanyl, don't care what substance you're using, it might have fentanyl, so have that naloxone and know how to use it, and have a plan. Have a plan around an overdose event. And I'll finish with a few more myth versus fact. Harm reduction encourages, normalizes, and really enables risking behavior. The moment that we're talking about enabling anything, it goes back to the stigmatization and the belief that this is a moral choice. And that individuals who choose to continue to use substances despite negative consequences, that they have the capacity to be choosing in a similar way from everyone else who does not have a use disorder. That is scientifically unfounded and untrue. These harm reduction just simply acknowledges this is happening, it's risky, how do we reduce these risks? Harm reduction opposes treatment or abstinence. Again, I think I've addressed that. That has been true. That myth has actually been true. We're moving away from that truth, and we're recognizing that everything that aims to meet people where they're at, see them for the human that they are, and give them the needs and address the needs that they have across the whole continuum of the human experience, any of that is actually treatment. So I simply don't differentiate between harm reduction and treatment. I do differentiate between a harm reduction approach and an abstinence approach if it is anchored on either pole. Either one is not the complete continuum. It's a recognition. I also will say that the people who we're trying to help here, they're on all different trajectories at different times. And it's our job to keep pace and be meeting them where they're at every time. We're often really good at meeting someone where they're at the beginning, and then we forget that they're human and they're going to be changing, and we have to continue to meet them where they're at. Harm reduction is, oh yes, love this one. Waste of public funding and resources, dripping with the sense that individuals who use substances have lesser value and their lives are not as important to be reducing risk. And I will offer to you that has been true across all chronic disease in history. SUD, substance use disorders, and those who use drugs are not the only marginalized, stigmatized population in the realm of healthcare. Those with chronic pain, horrifically stigmatized and judged. But pretty much most of the chronic diseases tend to have a degree of stigmatization. Within healthcare, the two variables that are most helpful to focus on is if people feel as though the individual with the illness caused the illness and should have control of the illness, then it's going to be stigmatized. So you see stigmatization around type 2 diabetes, obesity, HIV/AIDS, smoking, very much that they're stigmatized because of that cause and control. This one is very clear that harm reduction approaches actually reduce the expenditure of healthcare dollars in communities that fully embrace them. Why? Because it is really expensive to continue to have people going to the emergency room and to be hospitalized for weeks with infections or post-overdose. The treatment of infectious endocarditis is weeks and weeks and weeks of antibiotics in the hospital. If that can be reduced by harm reduction techniques, we save all of that money as a society and within our health system. So please come to me if you want to talk about this further, because that is me, done before noon, and now we can have lunch. So thanks, everyone.